Okay, we are going to get started. So my name is Jake Marples from the University of Michigan. I'm one of the student assistants helping out with the conference this year. Welcome to track 2. I will be moderating this track. The theme, as you can see, as you probably know, is COVID-19 planning and forecasting. You're going to have to forgive me for my lack of video today. There's a few moving parts behind the scenes, so I'm on a desktop computer without a webcam. I can promise you that I did brush my hair this morning and I am wearing a suit jacket, which now in hindsight feels a little unnecessary, but I digress. In any case, we have allotted 75 minutes, We have allotted 75 minutes to hear from 3 excellent teams today, as well as questions from the audience. So on the screen, you can see the 3 scheduled talks for today and their presentation order. Before anything else, I'd like to just quickly go through some guidelines and instructions for participants. So each presenter has 17 minutes to present. I would recommend for the presenters you take note of your time using a stopwatch if you are presenting live. One of our presentations today is a recorded video, so this will not apply. I will be giving 3-minute and 1-minute warnings via the Zoom chat as far as time goes. And then after each presentation, we are going to be moderating a Q&A for about 5 minutes. So the way the Q&A will work is that all of you are muted as a default. And I would ask that if you are not presenting to stay on mute, but in the Q&A session, you can click the raise your hand button by clicking on participants if you have a question in the Q&A session, and I will call on you and then you can unmute and then we can moderate the Q&A session that way. I guess another quick reminder is after this session, there is I believe there's a networking session via AirMeet after the session, so we'll have a reminder of that. So if you just joined us from the waiting room, we are about to kick it off with our first presentation. So the 3 presentations for today are on the screen, and I'm going to virtually hand it off to Anoop. Anoop submitted, there's a video recorded presentation, so I'm going to play that video in which he introduces his team and walks us through the presentation. So I'm going to play that now.
Hello everyone. This abstract number 11 was jointly authored by 3 persons. First, Anoop Khandelwal, which is myself. I am the co-founder and CEO of Kspire Solutions, LLP, Delhi NCR, India. We provide supply chain expertise in various sectors, including public health space. Second author is Dr. Laximikant Palo, who is the CEO of People to People Health Foundation, New Delhi, India. PPHF is in the public health space for the last few decades, earlier known as Project Hope. The third author is Mr. Soumyakant Dwivedy. He is the pro bono advisor to PPHF. COVID-19 has disrupted the activities of the entire universe at an unprecedented scale. As a top priority mitigation measure, the search for a suitable vaccine is being frantically pursued. Today, I'm going to talk about building robust storage capacity for COVID vaccines last mile delivery with reference to developing and LMIC countries. We represent India, where huge efforts are being initiated to handle vaccination as and when these are available. Let us discuss the objective of this study. The discussion is to evaluate ways and means to improve the readiness and efficacy of delivery of COVID-19 vaccine at scale by building a robust infrastructure and capacity for last mile delivery. Vaccination supply chains have been operating in their developing countries since decades. Then why is this topic pertinent in COVID situation? Vaccination. We will see why it is so critical. Talking about the context, number 1, the current situation, which is known to everyone, is that over 50 million people have been infected with over 1.2 million fatalities. talking about India, there have been over 8.5 million infections and 125,000 deaths and counting. Most European countries are seeing second and third waves, with fatality rates are also being very high, and the positivity rate is also very high. It is now given that without a vaccine, there is no way to tame this pandemic. However, this vaccine poses exceptional and unique challenges not encountered before. Let's see what are these. First of all, we have not handled a universal vaccination scenario ever. Till now, vaccines have been administered using a due list, which is not applicable in current scenario. Depending upon the availability of vaccine doses, a priority list is expected to be in place, which may be linked to a citizen ID like Aadhaar in India. Other key issue is adult vaccination, which is earlier was mostly restricted to immunization of children with pulse polio, drops, BCG, etc. Finally, the other peripheral needs like the vials, syringes, as these vaccines are likely to be injectable in nature. Above all, the need for expansion of cold chain infrastructure, which depending upon the vaccine, which is in the front runner vaccine from 2 to 8 degrees to ultra low temperatures like minus 70 or 80 degrees centigrade, providing single or double dose is also to be thought of. Governments are gearing up on a daily basis to address these challenges. So we have seen that the challenges are huge, which have never been encountered earlier in the entire vaccination the world has handled till date. The other context which we need to look at is that there are global alliances and bodies like COVAX are doing serious work to address the equity of availability. We need to look at the supply chain aspects for handling the storage and distribution of the vaccines. Secondary data points suggest that huge amount of efforts are required to augment the infrastructure. Prevalent supply chains are mainly procurement focused, with the planning being driven more by rule of thumb or heuristics. Warehouse infrastructure, though, has improved considerably in countries like India, still the issue of safe and adequate storage capacities, lack of adequate trained manpower, IT systems, cold chain infrastructure being inadequate. Yesterday's announcement by Pfizer that its RNA vaccine is more than 90% effective and is likely to be available faster than the other candidates. But this vaccine needs a storage condition of minus 70 degrees centigrade, which is almost not available or available in a limited space in developing countries. Lastly, the problems around the last mile deliveries on difficult remote locations without compromising on the efficacy of the vaccine doses is going to be the most critical aspect. This study has identified 3 critical drivers for better storage capacity. These are, number 1, distribution model, which can be centralized or decentralized. The second one is the warehouse space management. Availability of space both in public and private sectors, and the quality of this infrastructure is needed to be assessed. And third, the cold chain, where assessment of the total capacity with storage temperature ranges would be needed. So these are the 3 critical areas: the distribution model, the warehouse space management, and the cold chain is something which we have to look for. Moving on to how element as regards the storage nuances, we recommend use of network optimization techniques like LemmaSoft, which can determine the center of gravity of the distribution chain and provide the recommended storage locations from where the primary health center or the end user is at the shortest distance For smaller geographies, a direct model of distribution may be appropriate, but for large geography like India or Indonesia, a hub and spoke model is suggested. Warehouses will have to plan for storage of vaccine vials, syringes, PPEs, etc. And our estimate suggests that a volumetric space of about 100 to 125 cubic centimeter can be used for space planning purpose. Stock taking of storage space both in the ambient temperature range and cold storage will have to be gathered and collated. Our estimate further suggests that the ratio of 70:30 between the ambient storage and cold storage should be sufficient to handle the vaccine. The other aspect is the handling of the ultra cold chain vaccine and dry ice, which we will discuss a little further. Another key aspect on the storage space optimization is the vertical storage possibilities. Ground plus 3 or 4 or 5 levels is quite common and leads to efficiencies. Stores are recommended to be equipped with some local ERPs unless they already have such that the handling of expiries, stock visibility, and stock out alerts can be promptly handled. A simple Kanban system of replenishment responsive to consumption pattern can be adopted. Further, the distribution is also recommended to be part of demand management. Since dry ice may need to be used for last mile distribution, the safety aspects in terms of trained manpower with required regulatory approvals will need to be put in place. Amongst the hows to address the situation, we talk of distribution solutioning. It is said that products and services have not achieved their purpose unless they get delivered to the end user. A study finds there is a normal delivery efficiency ranges from 80 to 90%. There are challenges ranging from cost to quality of service level, especially in the villages. Schemes in India like the Pradhan Mantri Gram Sadak Yojana have achieved considerable metal road connectivity in rural areas, but the proliferation of e-commerce logistics has further revolutionized this sector quite rapidly, with competent third-party logistics vendors are doing micro last mile delivery and distribution quite effectively at very competitive pricing. They are really nimble-footed, they use technology, and they are really on the ball. Leveraging such players would be helpful. In remote, sparsely populated areas, the use of simple modes like bicycle to technological solutions like drones can be adopted. Another idea that may work in such scenario is to bring people to vaccine instead of taking the vaccine to the people. This shall also mean that cold storage locations which are predominantly available in large towns, urban areas can be utilized, and there won't be any need to have cold chain either in the suburban areas or packaging like dry ice, etc. will also not be required. Let's talk about the opportunities and how to handle the problem at hand. Talking of opportunities, considering the urgency, scale, and acuteness of the situation, a robust public-private collaboration is called for, where the private sector is expected to provide the following key imperatives. Number one, supply chain management expertise in public health. This is increasingly getting popular with more and more public-private partnerships with organizations using their corporate social responsibility initiatives. Number 2, industry experts having experience in driving supply chain innovations can bring in some fresh ideas into this public health arena. Number 3, leveraging the storage and cold chain assets which are available in the private sector. And number 4, leveraging on the quality manpower with commitment, with time and effort. Today, there are industry professionals who wish to give back to the society and provide such support either on pro bono basis or with very little consideration. Towards the end, let's talk about the recommendations. Some key recommendations which we put forth are that the public health supply chain can be strengthened by bringing in private sector expertise in areas of inventory management, storage, knowledge, and physical assets can be game changers. A strong public-private partnership is envisaged. Today, large UN bodies, philanthropic organizations are already quite active. Even bodies like ARC and IAPHL with industry experts are contributing in this area. A recently launched initiative by the authors of this article, that is by PPHF and Kspire, which the presenters represent, is the ASTA initiative, which is Asia-Africa Supply Chain Transform Health Alliance. That can enable support by mobilizing collective strengths and partnering for building sustainable, scalable processes. ASTA brings a platform of supply chain expertise to address specific supply chain issues besides other normal issues in public health supply chain. Thanks.
Okay, thank you, Anoop, for that first presentation. I can see that Anoop has gone off mute now, so we'll go into the Q&A portion. So if you have a question for Anoop, feel free to raise your hand and I will call on you. So I'll give you guys a few seconds for that. And if we do not have a first question, then I'll ask a question to kick us off. Okay, I don't see any questions yet, so I will ask a question to kick us off. So Anoop, you described a few of the different challenges in your presentation. I think on the last slide, you summarized some of the challenges regarding transportation, regarding IT, regarding, I think, manpower, as you put it. Of those challenges, do you think there's any that we will be particularly challenging to overcome, or are there any that you think are uniquely challenging as far as how we are addressing them right now?
Yeah, thanks, Dick. Amongst the challenges, I feel that the challenge of handling the cold chain is going to be a massive one. So as I mentioned in my presentation, that depending upon the vaccine candidate which gets approved, for example, the Pfizer vaccine, which requires -70, -80 degrees centigrade, is going to be really, really challenging. And only thing is that, for developing countries, there can be situations where, as I mentioned, that the patients can be, or rather the people can be taken to the vaccine, which may be stored in the urban areas, or there could be a situation where there can be certain period for which the vaccine is effective at certain low temperatures like 2 to 8 degrees centigrade, where the storage can be there and then in limited quantity can be administered. So I see cold chain as the management of cold chain as an important factor for the efficacy of the vaccination process. Thank you.
Thank you, Anoop. If you have a question, but you are unfamiliar with the raise your hand feature as well, I will give everyone a few moments. You can actually just come off mute and ask your question. So I will pause for a few moments in case there are further questions. Okay, thank you, Anoop, for that presentation. That was very insightful. We're going to move to track 2.2 now. So you should be able to see on the, you should be able to see on the screen the different tracks. We're moving on to 2.2 for those that are just joining us. I'm going to admit one more person from the waiting room. So Nabila, you should be a host, so you should have the ability to sort of share your screen, and then you can kick things off when you are ready.
Hello, everyone again. My name is Nabila Hamid from Global Health Supply Chain Technical Assistance in Tanzania. I will be presenting with Emily Magurno on customizing WHO quantification approach to the Tanzania context. GHSC-TZ supports the government of Tanzania in different areas of the supply chain, so we mostly work in areas of the public sector. So the first quantification for COVID-19 commodities was conducted in April 2020, and it was based on estimated case projections, and we used WHO's essential supplies forecasting tool. The quantification applied a morbidity-based forecast methodology that quantified requirements based on projected number of cases, taking into account the exponential increase and decrease of the pandemic, as observed in other countries. However, as the pandemic evolved, so did the country's response strategy. The country priorities then focused on protection of healthcare workers, provision of oxygen therapy, and continuation of targeted testing. This led to the second approach of the quantification. Now, as the quantification approach evolved, so did the scope, forecast method, supply plan, and implementation approach. In this case, all the country priorities were factored directly into the forecasting approach. This included oxygen and biomedical equipment availability, facility capacity to administer oxygen, country-targeted areas for PPE, and the types of healthcare workers that were available at different types of health facilities in the country. I've summarized this framework to describe all the major changes that took place during the quantification. We will go through each phase separately. I will cover the different processes that were involved at each level of quantification. Oh, apologies. First, across both approaches, we took into account the plan that was set in place. This included strategies to prioritize areas of intervention. And in Tanzania, we had Tanzania's COVID-19 contingency plan, as well as Tanzania's emergency supply chain operations guideline, TESCOG. Both of these strategies were taken on board during the quantification approach. Secondly, the scope of quantification considered the product list, patient groups, geographical setting, and health facility types. The forecasting approach itself went through different methodologies based on availability of data to support each. The supply plan considered the different lead times in place to support emergency delivery to the country, as well as emergency distribution to health facilities. And lastly, monitoring of the forecast and supply plan adherence was also factored in. During the first phase of the quantification, as I mentioned before, WHO's essential supplies forecasting tool was used. This tool was designed with a product scope that included PPE, oxygen therapy, testing, treatment, and medical supplies used for support. The list of prioritized products was over 120. The tool factored for all health facility types, and it was based on morbidity forecasting methodology. This was generally built on a vertical approach. As all the teams were still setting up to address the pandemic, an online Google Sheet was used for tracking forecasts, supplies, and funding commitments. After the country priorities were established, the quantification approach also changed. We now had to focus on PPE for selected areas, oxygen therapy based on available infrastructure and targeted testing. The prioritized product list also reduced to 20 items. And instead of forecasting for all health facilities, we now focused on targeted facilities that would be responding to COVID patients. One of the key features of the second phase of the quantification is that now we made plans based on an integrated systems logistics rather than vertical. This set the grounds for sustainability over the long term. Also, during the second phase, we now had ELMIS configured for end-to-end system visibility, as opposed to the previous online Google Sheet that was used. What this meant is that facilities were now able to specifically report for COVID-19 commodities that were consumed or that were required, and stakeholders at different levels of the supply chain now had visibility to that data. And so these are the phases that our quantification went through. Now, I just want to highlight a few details on how we customized the WHO tool specifically for oxygen therapy. There are several biomedical products for oxygen therapy that were identified by the tool in the first phase of the quantification for COVID-19 commodities. The product list in the first forecast was a mix of biomedical equipment for oxygen delivery that can be provided under essential critical care and advanced critical care. The difference between these two types of critical care is mainly based on complexity and cost of care. Therefore, a decision was made to prioritize requirements for oxygen-related equipment for essential critical care and the few for advanced critical care. Biomedical equipment for oxygen delivery and essential critical care can be used by majority of health facilities in developing countries. They require less complex skill set to manage or operate them and are cheaper. Therefore, more can be procured for wider distribution and availability to health facilities that need them. And this was most important during an emergency cases, what we faced this year during the COVID pandemic. Now, one of the key changes that were made to the forecasting approach was to categorize the oxygen biomedical equipment from the WHO tool into those required for essential and advanced critical care. This way, we could link requirements versus existing supporting infrastructure to be able to accommodate those equipments. In addition, rather than to split requirements by severity of cases, the tool was adapted to project requirements based on facility capacity to either provide essential or advanced critical care. The same customizations were made for the other product categories as well, to reflect country priorities and supporting infrastructures at health facilities. What we saw at the end was an improved tool that clearly reflected country priorities. This adapted tool provides new ideas that will be taken into account in future forecasts conducted for oxygen and biomedical equipment, PPE and IPC commodities. As we customize the WHO forecasting tool, we continue to learn the importance of data on health facility infrastructure and healthcare workers. I think we must all admit that throughout the whole process of quantification, and as we're all responding to the pandemic, it has definitely been a learning experience for everyone. Thank you for listening.
Thank you, Nabila. I'm going to go back to our screen sharing here, and we are going to jump into the Q&A. So I will give you guys a moment. Use the raise your hand button if you have a question that you'd like to ask, or conversely, if you're more comfortable, you can also write that question in the chat. I will give you guys a few minutes for that. Otherwise, I will ask a question of my own to kick us off. Looks like we have a question from Susan.
Oh, thank you. Thanks so much. Well done on a very, very good presentation. I'm particularly interested in how you managed to integrate the forecasting or quantification for a variety of products. And I just wondered if you could comment on the approach in terms of involving a wide variety of stakeholders to provide input into that integration.
Thank you, Susan. Thank you for your question. So around integration, one of the main factors that changed during the approaches and countries' priorities is that we now wanted an integrated approach rather than vertical. So there are a few areas that remained to be vertical, but areas such as the pharmaceuticals that were required for case management of COVID-19 commodities, all those were turned to the integrated logistics approach. And what that essentially meant is that when it came to medicines that were needed to treat COVID-19 patients, and we know that in some cases there can be comorbidities, and those comorbidities are part of daily or existing diseases that we treat on a day-to-day basis. In that case, we did not need to have a vertical approach for items or commodities that were already there in the system. In this case, such as for pharmaceuticals, these were then part of the integrated logistics system. Your other question on how we were able to work together with different stakeholders and different organizations throughout this process. So in Tanzania, we had the logistics pillars that were used among the other pillars that were used to bring together stakeholders from different areas in order to bring in ideas or concerns or areas that they could support or needed support in order to address the COVID-19 pandemic. So through these pillars, we had regular meetings and were able to communicate. These pillars were able to connect stakeholders from the private sector, stakeholders from the humanitarian logistics area, as well as the public sector. So in instances whereby maybe challenges were mentioned or raised in terms of probably clearance or bringing in or expediting incoming shipments for COVID-19 commodities, especially at when they were entering through Tanzania, then the public sector government was there to be able to provide that support in order to expedite movement of the products. I think I have covered those questions. Jacob, should I also respond to the questions in the chat box?
Yep, it looks like Anoop had a question about cost. I'll let you take that, or if you need further clarification, you can ask Anoop about that.
Thank you. So the original WHO tool that was so Anoop, the original WHO tool that was shared on the WHO website and of which all countries were advised to use, that was free of cost. The adopted tool that was made in the country, that was part of the technical assistance that our project provides. So there was no cost to that either. Please let me know, Anoop, if I have clearly answered your question.
Okay, it's fine. It's fine.
Thank you.
Yeah, thank you. Thank you.
Okay, thank you, Nabila, for that presentation. I know things are slightly strange with this virtual conference, but I'm giving the little clapping emoji via Zoom. So thank you for the presentation. And now we're going to move on to, excuse me, let me go to my slides. We are going to move on to the third presentation here. So I'm going to, per our discussion beforehand, I'm going to present my screen, and Lade, I hope I'm pronouncing your name correctly. Please correct me if I'm wrong. Feel free to unmute and when you are ready, and we can get started with this third presentation.
Thank you so much, Jacob. Good evening, or good morning, good afternoon, depending on where you are. My name is Lade Stephen. I'm the country director on the GHSC-PSM project in Angola, implemented by Chemonics International. Today, I'll be sharing very briefly our experience on supply chain preparedness and response through approach redesigns and partnership in Angola during the COVID-19 pandemic. And other co-authors for this abstract are Roberto Gomez. Roberto Gomez is our commodity security manager on the project. Also, Ulika Kupatia. Ulika is our FASP advisor. Jani Souza is our family planning advisor, and Manuel Masamba is our malaria technical advisor. Next slide. Thank you very much. So in Angola, the GHSC-PSM project is implemented through three key program areas. We have the PEPFAR implementation under task order 1 for the HIV/AIDS response in country. This is implemented in 4 provinces out of the 18 provinces, and at the central level, TA to the government. This is about 10% of our total annual budget. And secondly, we also implement the malaria program supply chain under the President's Malaria Initiative, both for commodity support and technical assistance to the National Malaria Program, and implemented also at the facility level in 6 provinces of the country. We also provide, and this is about 80% of our annual budget on the project. Then also, finally, we also implement the family planning and reproductive health supply chain technical assistance with some commodity support to the government in at the central level, and providing technical assistance for ensuring commodity availability across the 18 provinces, but without physical presence in the provinces. For the other 2 programs I mentioned earlier, we maintain physical presence in these provinces. Next slide. So during the COVID-19 pandemic, the thrust of the discussion today came because we anticipated the crisis and tried to frame what the challenges were and how we could go about resolving them as we would face them. So how did we frame the problem statement? One was to say, how do we rapidly respond during a crisis as the COVID-19, which there was limited experience, right? previously to leverage, and in anticipation, we didn't really know what was coming, but earlier on in the process, we began to ask ourselves, this crisis that is about hitting the supply chain, what do we do to begin to plan? How will we position the projects to rapidly respond and provide solutions? Secondly, we also understood in hindsight that as a foresight that the project funding was usually an annual activity, right? So we get one approved project funds per year. So it is already fixed even at the time we were being faced with the pandemic. So how do we get to make sure that the project funds that were fixed will be able to address more issues that we would face in the various forms that they will come to hit the project? And also because of the shifting resources within the public health space to COVID response, we also began to ask the question, how do we utilize what we have to be able to respond to our ever-growing need at this time? And we, like in most other countries, we also experienced the government restrictions, and we had to ensure that commodities still get distributed in the face of these restrictions and the resource constraints that I described earlier. So our objective within the period was to ensure that we continue the project implementation uninterrupted while ensuring that our staff continue to stay safe and our implementing partners and counterparts are also safe in the process. And how do we find new ways of doing our old work without compromising quality? Next slide, please. So as I said a short while ago, we in country, we saw that there was, immediately the COVID started, there were significant change in decision by governments to focus more on providing the response. This, of course, resulted in some form of neglect for the programs where we work. So we had to take some strategic decisions and actions to ensure that the project funds that were available could continue to support both us and the work that we had to do with the counterparts without allowing for gaps. And this meant a higher burden on our limited project funds and with no plans to increase the funds. So we had to focus on how do we mitigate the impact on our supply chain to minimize disruptions at the sites where we provide support. How do we make sure that at every point, because of the growing restrictions and the uncertainties with the rapid changes with which the government decrees were coming on with the restrictions, how do we ensure that commodities stay close to the end user at every point as much as possible? And with the shifting priorities on the side of the government, how do we stand ready as a project to support even the government in the environment where we work to ensure that they are able to continue distribution for the government's portion of the implementation? So we also had to begin to think of how to position the project to respond to ad hoc requests that would come from the government, and how do we establish updated early warning signals and KPIs to ensure that we continue to track performance and the anomalies that continued to spring up. Next slide. So what was our methodology for success? Next slide, please. Thank you. Realizing that our work plan was fixed and there wasn't, as with respect to funding, we were working within a defined space. We reviewed our work plan, which we had gotten approval for about 4 months prior to the conversations on COVID, to begin to reflect the present situation and the anticipated changes that the COVID would bring. This meant reviewing our budgets to align with the new priorities that we would face. We didn't do this alone. We worked with the government counterparts and our other implementing partners to identify what the risk would be and to propose jointly mitigation plans. We made sure that across the central and the subnational levels, we communicated widely on the approaches that we were envisaging to begin to adopt and to share with our partners and the counterparts what our change in strategy would be, so that they would also begin to think along that line and help us to identify on time what gaps were within their system that we also needed to fix on our end or to support to ensure that there were minimal interruptions to the activities on the project. And then we set out to implement these activities while at the same time ensuring that our staff and all those involved were both safe, and we continue to keep an eye on the security situation as some measure of unrest was also experienced. Next slide. So some of the specific activities, the slide before, sorry. Some of the specific, hi Jacob, thank you so much. Some of the specific activities that we changed, I'll just highlight a few and what differences we made. For Angola specifically, there are 18 provinces in the country. It has a large landmass and the road networks are really bad. So within the COVID restriction, to move products between the provinces from the central level and to the facility level was a challenge. So for our biggest portion of the project, which was for the malaria supply chain, we currently work with third-party logistic agents. However, because of the travel restrictions, like I said, the challenging road network and the inability to be able to move around as easily as we used to, we changed how we delivered the commodities to the facility level. Previously, we had an agreement with the government where we took commodities up to the provincial level below the central level, and the government counterparts, our advisors would support the government structures at the provincial level to move the commodities to the municipalities where we maintain a limited amount of stock because of storage concerns, and then subsequently these get moved to the facility level. But with COVID, we did not have the luxury of time and all the resources to be able to wait to just deliver to the provincial level. So we had discussions with our counterparts and the partners to prioritize the big facilities and then to move a step lower in the chain to the municipal level. So the project delivered commodities directly from the central level to the municipalities and to the high volume sites in each of these provinces. This cut the risk of, okay, the government vehicles and other resources, which were largely, one, not operating in full capacity because of the need for social distancing and because of the shifting resources to address all the COVID restriction. With this change in our distribution approach, we were able to cut off that risk and minimize the the risk of commodity being stocked out at our facilities. While we were getting this implemented in March, we recorded stockouts of up to 50%. But with this, when we implemented this, by June, we had reduced the stockouts across more than 80% of our supported sites to less than 10%. Next slide, please. At the time, just before the COVID hit Angola and the borders were closed, the country was transitioning on the HIV/AIDS program to TLD. We had just secured ministerial approval to transition all patients to TLD. And the first step in the process was the quantification exercise and the registration in country of the products. Now, with the restrictions, people could not come to the office. There was no way where we could do quantification the way we used to do it traditionally. Would sit together, collect data, and then review the data, clean up the data, and then in a joint consultative forum, we would get consensus from stakeholders, and then develop the reports and present, and then we consensus. The reports are approved by the national program and disseminated to stakeholders. But with the COVID, it was not possible to meet, and the government didn't have experience, also doing this remotely. But in conversation with the project, we recommended to transition. We agreed to hold everything, including the data collection, the data crunching, the data review, even onboarding the STTA, who was supposed to fly into the country from Addis, but then with the border closure could also not come in. So if the procurement of the process for the STTA, the data crunching, every process was carried out remotely. And as you can see on the screen, screenshots of people in different locations working together to deliver the quantification exercise, because this was very key for us, especially that we had to implement two key policies in the country at this particular time, transitioning to TLD and ensuring that the multi-month dispensing was implemented in country. So the quantification team worked together to develop the quantification that determined the TLD needs for the country for all patients that were to be transitioned, and to plan for the procurement and to share the information across the different donor groups, and to also advocate for funding on behalf of the government, so that we could plan we could develop the supply plan with adequate information. So it was challenging, but it was also an exciting experience to be able to conduct for the first time remote quantification exercise in the country. Next slide. On the family planning and reproductive health program, our funding typically does not allow for, we don't have typically funding to distribute commodities from the central to the facility level, because the funding that we have approved is limited. So we made a strategic decision in consultation with the government to put all the funds into commodity availability, and then we would leverage government structures to get the commodities delivered. But with the COVID, the ambulances which were typically used for the distribution were now repurposed and more focused on COVID response. So it wasn't possible to access these vehicles. And for the central level distribution by the government was usually happens quarterly. With COVID, the warehouse was packed full with COVID supplies, and that was where the attention was. Then the commodities that were coming in country, we know also that within the COVID period, there was a high demand for contraceptives. So the partners usually do separate distribution, but now here we were with some contraceptives arriving just at the time that the lockdown was being announced, and we didn't have funds to distribute them. So we had to collaborate with the World Bank and available government structures that were carrying out distribution. The World Bank commodities, funded commodities, were supposed to be distributed in only 10 of the health facilities, 10 of the provinces, because that was the focus for the commodities at the time of planning. But with advocacy and continued discussion, we were able to secure the concurrence of the project leadership to consolidate distribution with the USAID funded commodities for distribution, and this all got distributed to the 18 facilities, to the 18 provinces. So it's through advocacy, we're able to expand the geographical coverage, and we were also able to leverage the resources of other partners to ensure the distribution. And on the side of the government, we worked together on the distribution plan, and where there was allowance, we leveraged the transportation mechanism to put whatever limited commodities, family planning commodities that could go on the trucks to ensure that the distribution to the facilities, to the provinces, and subsequently to the facilities were carried out. So we tracked this remotely from the central level via calls, via WhatsApp, almost on a daily basis, having WhatsApp calls with those who were not able to meet on Teams. So whatever means of communication was convenient and possible at the provincial level, we leveraged this to ensure that the products got to the sites they were meant to get to. Next slide. For our 3PL contracting, at the point where the COVID struck, we were reviewing our contracts. We were at the point of engaging new vendors. So with the changes, we had to make a quick decision on what kind of contracts we would sign up at the time that we were making this decision. For storage, we decided to stick with one service provider because of the uncertainty of clearance and having to move commodities around. So we awarded the storage contract to only one vendor, but with the provision to change strategy midstream if we encountered any challenges. So we made that allowance to glean lessons and then to determine if we needed a second contract. For distribution, we took a different approach by engaging two service providers rather than one, so that we could always have that opportunity to be able to move irrespective of whatever challenge any of the vendors was facing. But this put into this way, for each of the circles that we had to do a distribution, we competed the bids, and we chose the most cost-effective quote, even though there were times that we had to do a trade-off for what was most feasible given performance and the situation on ground. But these were using very defined and spelled out decision points. And then we maintained our KPIs to ensure that we could track performance of the vendors as well as track anomalies, because with the restrictions, with every new trip, there was something new for us to learn and to make changes, So we updated our KPIs to be able to catch both the performance and the anomalies, and we made it in such a way that the anomalies, the vendors did not get, it was not punitive, so that the vendors will also be able to report the anomalies in the midst of the distribution exercise. And then, as I mentioned earlier, we used a lot of communication tools, whatever was convenient and possible for the government folks we were interfacing with at every point to ensure that our implementation did not stop. At the time the state of emergency was declared, our condom shipment was arriving. So how do we finalize the distribution plans, get approvals, and then coordinate for the distribution of the condoms to the provinces and to the sites? So our team coordinated via Teams, via WhatsApp, via group emails, via text messages, whatever means of communication on a daily basis. We had to interface with the warehouse, the program, the distribution agent. We used all avenues to make sure that we could communicate and activities did not have to stop. Based on what we have seen so far, what are our next steps? One, we want to, using our KPIs that we developed, we want to continue to improve what we have learned and provide even better services going forward and sharpen our implementation. We also learned that there is a private sector engagement is key. So the lessons we learned, because for our clearing, for our distribution, we found that it was easier to move when we engage with the private, for the sections and the portions of our implementation that had the component of the private sector. So we also want to continue to strengthen the private sector engagement through the project and on the side of the counterparts, sharing the lessons that we have learned. And also advocacy and collaboration. We will continue to do this to ensure that we can continue to implement, working with the other implementing partners with the programs, and getting the programs to also leverage the strengths across the programs rather than always just focusing on vertical implementation. And in addition, we also this opportunity would also, we're also looking at how to ensure that the government budget captures plan for in-country logistics, both acquisition of commodities, so that like what happened during the COVID, where resources were just automatically shifted. If there was a plan where in-country logistics was clearly captured on the project, on the government budget, it might have been would have been less difficult to channel. It would have been easier not to get the funds repurposed, right? Because the funds would have a name. And based on all that we have learned, we want to use our experience as a proof of concept to share continually with our government counterparts and the partners that we work with, and then to use all our lessons to develop a plan for future crises. So what were the key messages and the key learnings that we took from this experience? One, we found new ways of doing the same old things, but we can get better results even under a crisis period when we focus on what is important. We also found that even though the crisis hit, the recognition of the expertise that is available on the project and within the implementing partners enhances supply chain agility. And also the ability to be able to think fast and work in a collaborative manner. It improves supply chain agility. Then we also found that even though the crisis resulted in a change, not only to address the crisis, but also to change the way in which things were done, not with the mindset of just to stop once the crisis is over, but even after the crisis, the changes that we have implemented, that we have found that, oh, this provided an opportunity to do things better. How do we retain that? We would like to carry those learnings forward. And it is possible that in a crisis period, you can experience changes that made your operations to even be implemented in a much better way than you were doing prior to the crisis. And we also learned that it is possible to reduce supply chain costs during a crisis if you are able to focus on what is important. And even though you may not be able to implement the full suite, you will be able to determine what is the minimum, what is the MVP for this crisis moment, and how do you use the funds that you have. It will be you will be surprised to see that you can even have cost savings, but like I said, you may not be able to implement the full suite, because even in a crisis, how much of the full suite is really possible and needed? You focus on what is really important and how do we get things done. And then we also learn an improved way to track our 3PLs and our own performance using the KPIs that we defined within the period. And these are our learnings, and would carry this forward, as I said earlier, to share our experience with our counterparts and with implementing partners that we work with within our space, and to carry our learnings even post the crisis.
Thank you, Lade. We have a few minutes now for a Q&A. I'm going to kick us off with a question, and then following my question and Lade's answer, if you have another question, feel free to raise your hand or post it in the chat. I think we have about 3 minutes or so for a few questions. So the first question I had was, you talked about how the pandemic had implications in a variety of supply chains, creating a variety of problems for things like the anti-malarial supply chains and the family planning supply chains, with some of the ambulances being repurposed. So one of the questions I had was, how did you approach, given it sounded like you said that there were sort of limited budgets and limited resources to address these problems that were popping up in various supply chains. How did you approach prioritization about sort of understanding that a variety of problems have come up? How did you approach figuring out which ones you wanted to tackle first or put the most resources into solving?
Thanks, Jacob. As I said at the beginning, right, we started the prioritization even before the borders were closed. So before the crisis hit us, we had started prioritizing. So we knew for a supply chain project like us, what was the most important was getting products to to the hand of the end user. So it was easy for us to decide all activities that support this, that we cannot do without, would take first place. Then the second thing that helped with prioritization was collaborating with others, like in engaging with the government counterparts and with the stakeholders. We were able to agree on, okay, based on all that we agreed to do within this 1 year span, now it's not possible for us to do everything based on the situation we have found ourselves. What do we agree on prioritizing now? For instance, when we had to do the routes review, we sat down together and said, now distribution to the provincial level is not in the best interest of our implementation. What should we do? The clinical partners gave us a list of the high volume sites, even though on our reports we could see them, right? But having that come from other stakeholders within the space helped to pull every resource. So at the provincial level, we have, when our advisors are trying to support the distribution, because everyone contributed in the decision, it helped with the implementation. So the engagement and collaboration with the government and the other implementing partners within the space also contributed to our prioritization. And then big of all, on a donor-funded project, your donor you are very clear on the mandates and the priorities of the donor. So that in itself helped with prioritizing, because that was settled at the beginning of the fiscal year, what the mandate and what the priorities for the year were. So based on those three broad categories, we were able to easily know what to focus on first and what was most important in the midst of changing situations.
Thank you, Lade. We are a minute over time, but I will give anyone an opportunity. If you do have a final question, I'll give you the opportunity now to just go ahead and unmute yourself and ask it or type it in the chat. So I'll pause for a few moments for that. Otherwise, I will sort of close us out and transition into the networking segment. Okay, thank you everyone for attending, and a special thanks to all the presenters. We had 3 very interesting and unique presentations today. So thank you again to those presenters. Some reminders for day 1. In the Google Calendar invites you should have received, there is a link to AirMeet, which is a tool that's used for kind of virtual networking. It shows virtual tables that you can join and sort of meet some new people. Obviously, this is a little bit difficult given that we are in a virtual setting as compared to the conventional conference that happens every year. But from 1 to 1:30, so we were already 2 minutes into that time. But for the next 30 minutes, there will be sort of open networking via those AirMeet links. So I will conclude our session now. Thank you again to everyone that presented or attended. And I will close out the session, and feel free to join the AirMeet links to ask further questions to any of our presenters. These links will be open to not just track 2, but from all the tracks. So thank you again, and enjoy the rest of your day, everybody.
Thank you, Jacob. Thanks, everyone.